Vice Chancellor, sir, and my dear friend, the chief guest, Vidya Jyoti, Senior Professor, Perera, Desanayaka, Madam President, all the office bearers of the Anuradhapura Medical Association, members of the Anuradhapura Medical Association, and distinguished invitees. I stand here in all humility, totally bewildered at the honor that has been bestowed on me today in being asked to deliver this keynote address. Madam President, I'm very grateful for those very kind words of introduction. But to start off with, if you look at the entire animal kingdom, the arrival of a newborn is a cause for tremendous joy. And I think it is so today for all of you here in Anuradhapura. We have seen the birth of a newborn baby in the form of the Anuradhapura Medical Association. I start off as it happened in 1965, before many of you were born perhaps, that I entered the Faculty of Medicine, Colombo, as a very raw, totally unpolished 18-year-old medical student. And in 1970, the centenary year of the faculty, I qualified with MBBS, just second-class honors at the age of 23. And today, at a ripe old age of 70+ years, with over half a century as a doctor under my belt, I have been asked to talk to you about professionalism in medicine. And it will be an addendum to what our chief guest told you so far. And because these are going to be some random musings. Now, I don't think many of you realize that as somebody who has had some contact with sports, where records are seen, that you have honored me with a record that can never be equaled nor bettered. Because there can only be one inaugural foundation sessions. So if there has been only one inaugural foundation sessions, the keynote in that sessions would be the record that cannot be equaled or bettered. So thank you very much, and I'm ever so grateful for that honor that has been bestowed on me. What I'm going to talk to you would consist of an introduction to some aspects of professionalism in medicine. I cannot obviously deal with everything in that. And thankfully, I think our chief guest has dealt with quite a bit of it. And 4 notable anecdotes, which I hope will perhaps hold your attention, and some concluding remarks. Now, what is professionalism in medicine? I've given you the description from America and the United Kingdom. But what I like most is this one, where there is a synthesized composite definition, and the last line where it simply puts the patient first. There are some finer details to it as well, of which I have just selected just 4. They are professional behavior, punctuality, day-to-day work, the dress code, and things like that. I think many people don't attend to these things, and therefore I thought it might be useful. If you look at in detail, the professional behavior, you have to be courteous and polite in communication, have kindness, respect, and clarity of the content that you convey to your patients and their relatives. There is absolutely no point in telling a very ordinary farmer that he has got itama darunu susana paddhatiye ආසාදනයක් හැදී තියෙනවා, he will not understand a word of it. You will have to come down to his level. And also, when you listen and discuss with a positive attitude with your patients. Ethical practice, confidentiality, you have already heard about it, and fairness and equity in treating patients. Whether you are treating a pauper or the highest in the land, I think it should be the same. I have been taught this over and over again when I was a medical student by very many top people in the country whom I have venerated right throughout my life. There is responsibility and accountability. We exert a lot of power on our patients, but with that power comes a responsibility. Honesty is a vital element, and you take responsibility for any mistakes that you make, because we're all human, we do make mistakes, and be open to feedback and even criticisms. Punctuality, respect for other people's time. Madam President, I'm so glad that your program today is running ahead of time. And also, that would give me a few more minutes to speak as well, I hope. Being on time is respecting others. And patients' time also matters. Some of them, and some of them may have come from long distances. Thank you. And also the time of your colleagues and fellow workers as well. So you do have to manage time and plan ahead, depending on the numbers of patients which you have to sort of make sort of allowances for. Consider possible delays and unforeseen occurrences, like what might even happen to you on the way from your home to your place of work. It might be a small accident for all you know. And be prepared for the event when you ultimately reach the place where, whether it be a ward round or whether it be a meeting or whatever that you have to come in time for. Day-to-day work, optimal level of care, obviously, I don't have to tell you this. And you have to be up to date and not a frog in the well. Whether you have just qualified as an MBBS doctor or whether you have qualified as a highly qualified specialist, I think continuous improvement in your academic setup is in your own self is going to be that much important. Consistency and reliability in your work, and also remember that patients come to us in their most vulnerable state. So be warm and understanding. This word empathy is vital. It's not the same thing as sympathy. Empathy is different. It means try to put yourself in their shoes and look at the world through their eyes. And teamwork and collaboration. No man or woman is an island entire unto himself or herself. No doctor can work in isolation. We need to work as a team. So respect and support your colleagues. Share knowledge and uplift the entire team. And finally, the dress code. Why is the dress code so important? A professional appearance conveys competence and instills trust in the patient. Trust is vital in our day-to-day management of our patients. It sets a tone for how you are perceived by patients, peers, colleagues, and the community. Suitability for the occasion, strike a balance between the needed attire and comfort. Dress-wise, there are terminologies like formal, official, and casual. They have their own definitions. And if you're not sure about what it means, please do ask or look it up. And today, I think knowledge is there for all in the internet. Inappropriate dress may undermine your credibility, and I bring you a little anecdote, an additional anecdote about a safari suit episode. And this concerns the same great friend that I have had, whom your chief guest mentioned, Dr. Denis Aloysius. I was asked to give an equally important keynote address once at the Sri Lanka College of General Practitioners. So I prepared and went and gave the lecture, and at the end, Dennis took me to a side and said, "That was a wonderful presentation, but your dress is not all that wonderful." I was in a beautifully tailored safari suit. So I said, "Dennis, look, it's a foreign tailored safari suit." I said, "It's bloody good for you to wear a safari suit if you are going on a safari to Africa, but not when you are giving a keynote address to the Sri Lanka College of General Practitioners." That's the first and the last time I ever wore a safari suit and as you see today, I'm in all my glamour because of the respect I have for my audience. Making clinical notes is an important thing. Many people don't realize that it's a vital and crucial aspect of healthcare, and health records are legal documents. Clear and legible handwriting is essential, and many people have said to use, if your writing is bad, use capitals or uppercase letters. Date and time, this is crucial. Those who have worked with me know to their cost that this is absolutely vital in my unit. So put the dates, the time, and all that details in that. Now, for instance, you can see there I have put 18, 10, 20. Now, many people enter the dates like that. What does that mean? Does it mean 18th of October 2020 or 20th of October 2018? Which one? Then 8:10, just plain 8:10. Is it in the morning, AM, or is it in the night, PM? 12? Is it noon or midnight? Now, in a court of law, you'll be in trouble if any of these gets to a judge and a very crafty lawyer. Why can't we write 18/10/2020, which makes it very clear that it's the 18th of October 2020. Now, many people write VP scene. What does that mean? A judge in a court of law might say that was the VP who was seen in the ward. There's nothing there to say that he has actually seen a patient. So why can't we write seen by the VP, or still better, examined by the VP? VP or VS or VOG or whatever is appropriate. Prescription writing has the potential to cause major problems. So you again use capitals, uppercase if you have to, if your writing is bad. English, because all these things are written in English. The king's language, because there's a king in the United Kingdom now, and the language of kings and queens. Talking of this language, I think this is going to be quite important, at least I think so. Your communication with patients would be in your mother tongue, mostly. It should not be a problem. Whether it's Sinhala or Tamil, it shouldn't be a problem, because it is your mother tongue. However, most of your work and official communications would be in English, whether you like it or not. Proficiency in English is absolutely essential, but it's a real problem for some, unfortunately. No one will make allowances because it is your second language. Good command of English is a reflection of your professionalism. Proficiency in English does not come automatically. One has to work at it and try hard to develop it. Now, I take you back in time to 1960 and 1960, very definitely long before many of you were born. In 1960, my parents changed residence from Kandana to Dehival. So I was having my secondary education at Dimasnad College, a fantastic school by all means, but not very strong in English at that time. It's different now. And I was put into St. Peter's College in Colombo 4, Bambalapitiya. And in 1960, I was in the 8th standard. So I had been taught all along in Sinhala. English was taught as a subject, but I wasn't the most brilliant in that. So in 1960, I was all right because everything was being done in school in Sinhala. So I was within perhaps the first 3 or 5 positions in class. This new student who has turned up and was doing reasonably well. At the end of the third term in 1960, all my teachers decided, you're going into the bio class. You're going to do biology. Because they decided. I had absolutely no idea what biology was and what this means. But because they said and they forced me, I went into this class. And lo and behold, I had a major problem. Religious knowledge and Sinhala were obviously taught in Sinhala. Everything else was taught in English. Now, I could not speak English. I could not write English properly. I could not understand English. So, major problem. Towards, I think, the second or third week in that class, and I was in the GC O-level first year class. So all the science subjects were being taught in English. I couldn't make head or tail out of any of that. And we had English also being taught, and they were taught by a burgher gentleman, a scholar in French and English, who was an English master who was very, very poor in Sinhala. So he one day got us to write an essay, and all of us wrote. He took all the books and took them home, corrected it, brought them back the next day and distributed it to the boys. He distributed all the books except one. And that was my book. And he called me to his table. And he was trying to tell me in English what kind of rubbish I had written. And I couldn't talk to him in English. Therefore, I was trying to tell him in Sinhala what brilliant essay that I had written. And there was a complete impasse. Neither of us could understand the other. But there was one sentence of 7 golden words. You will not get anywhere without English, that this master came out with. Somehow that sunk into my brain. Because it was a huge stumbling block for me. So I decided that I had to do something because I was told very clearly, at least I understood that part of it. He said, you will not get anywhere, that part of it at least that he said. So when school closed that day, at I think 2:45 or 3:15 or something like that, I went to the library and looked around and picked up one English book. And we were allowed to take that home and bring it back the next morning at 7:45 in the morning and return it. So I took the book home and tried to work through it. Oh my God, that was all Greek. So English or Greek were the same to me. I couldn't understand. Now my father was a colonial public servant who was fluent in all 3 languages. My mother was fluent in all 3 languages. All the dictionaries were there at home, all the English papers were there at home. But I was so damn bloody wild-minded that I never made an effort to learn this language. And then on Friday, you're allowed 2 books because of the weekend. You return it on Monday. So I used to wade through that, burn the midnight oil, work through them using this thing, and whenever I was in trouble, I went and asked my mother first. And if she was not quite sure, I used to go and ask my father. And this went on like that. I spent a whole lot of time. And by that time, actually, what happened was that my grades had dropped. For someone who was within the first 5 positions in class in the 8th standard, I was very close to the last man in the class. Right? I barely managed because at least 2 subjects were done in Sinhala, so I could get some marks out of those. That is Sinhala and religious knowledge. This went on like that. And then gradually perhaps things improved. And it took an intense Herculean effort to come out of this. And then obviously when you try that hard, there is gradual improvement. There was a burger boy seated next to me in class, Ralph Menezes, to whom I hadn't spoken for 1 year because I couldn't speak to him in English. He's also a doctor, by the way, and he's abroad somewhere. He's in my junior batch. Obviously, as I said, gradual improvement was there. And then, of course, I was in the O-level class. At the end of the first year, I could barely manage. My positions in the class were also improving a little bit. By the time I sat for the O-levels, at the end, I was almost on par with my peers because through sheer work ethic that I had employed. And Madam President, I don't think I had all those results at the O-level that you had. But I had 2 distinctions and 5 credits. But mind you, that time, they were fairly valuable. And that meant that I was allowed to go into the advanced level class and try to get into the university to do medicine. So my efforts at language continued. And in the A-levels, at the end of the first year, I was ahead of my peers. I'm happy to say that. I'm not a MP, HOT, a monkey praising his own tail, but this is exactly what happened. So by the time I entered the faculty, I could hold things on my own without any problem. But I'm trying to tell you that how much effort it took. Virtually sleepless nights. Many find it difficult to even believe this story when they listen to me now. But I relate this openly and in public to encourage others. And as Doris Day, the great American actress and singer, said, if I can do it, you can do it, anybody can. 15 years later, the real fruits of this endeavor were enjoyed in England from 1975 to 1978. And where I went there for my postgraduate studies, I could hold my own very comfortably against the British. And no trouble in doing the paper. There was enormous amount of paperwork that had to be done. And we had to, every patient who had discharged, we had to dictate a discharge summary which ran into sort of sometimes 4 or 5 pages. We had to dictate it to a dictaphone, and the secretaries used to type it. And I used to always ask these British girls, the secretaries, can you actually really understand what I'm saying over the dictaphone? They said, Doc, we have no trouble with you at all. We have more trouble with the Englishmen because we can't make out what they are saying. The real jewel in the crown was when I sat for the MRCP exam. That time there was no pediatric MRCP, had to sit for the adult MRCP. And I had a very pleasant English lady, middle-aged, whom I had to present. And halfway through this, she suddenly turned around and asked me, Doctor, which year were you in Oxford? I said, I'm sorry, ma'am, I have never been to Oxford. I don't even know where it is. She said, it can't be. I said, why do you ask that? She said, you speak the most perfect Oxford English. I said, what's the difference? English is English. There shouldn't be any difference. No. She said, Oxford English is English without an accent. All the Englishmen have various types of accents. When they speak, you don't have any. And if you listen to our Queen, at that time, Queen Elizabeth II, that if you listen to her, she speaks in Oxford English, and that's English without an accent. I don't think I could have expected any of that when I was struggling all those years ago. Now, this is a verbatim transmission of a letter written by a highly qualified pediatric subspecialist, a colleague who wrote on something or the other to the president of the Sri Lanka College of Pediatricians, complaining about something. If you read through these, I don't think we have time to read through, but I've highlighted for your benefit some of the things that are obviously off. There is almost a mistake in almost every line, right? And can you imagine somebody writing like this after such good training abroad? And to me, that is some degree of lack of professionalism. Now, the problem there is, of course, today's belief of this kaduwa business. Akka, Nangiya, Ayya, Malli, and kaduwa. I believe that this, what they mean by kaduwa, many people who disparagingly remark about this, is that the kaduwa cuts your throat, I think. To me, English language is also a kaduwa, but it is a kaduwa that has been used and can be used to cut through all the barriers that we have which prevent our advancement. But more importantly, it can also be used as a key that will open very many doors to the world. And you already heard about my position in the Sri Lanka Journal of Child Health and the Ceylon Medical Journal. In the first journal, I have been there up to the present time for 25 years, and in the Ceylon Medical Journal for the last 16 years. And although I say so myself, that these positions are not given to every Tom, Dick, and Harriet. I think you have to be competent in the language before you become an editor. Now, ladies and gentlemen, I'm halfway through, but I'd like to present the 3 real-life anecdotes. First one, as a pediatric registrar in Sri Lanka. The second one, as a registrar in general medicine in the UK. Third, as a specialist consultant pediatrician in Sri Lanka. And they have 3 themes on which these stories are based. First one is on caring, second one is on altruism, and the third one is my being wrong, but lucky. Ladies and gentlemen, the word caring in medicine could be used in at least 3 different contexts. You already heard about this from our chief guest. Caring for the value of precious human lives, caring for the well-being of our patients at all times, and caring about the overall welfare of colleagues and others. All that goes into the caring business. Now here I've defined the caring medical professional. You see the resemblance of this, at least in the last line, to professionalism. Patient-centered care, patient's interest before all other considerations, it is the bedrock of medical professionalism. If you put the patient first, everything else falls into place. And that includes giving your ear to patients, doing all you can for the patients, and accepting that humans are not infallible, that we do make mistakes. I have done very many in my life as well. And hopefully, none of them have been very severe enough to account for a death. There's a huge difference between hearing something and carefully listening to something. One may hear loads, but may not be listening to most of them. Listening is a very active process. You have to concentrate on it. One who cares listens intently to patients, relatives, and others around, including colleagues and staff. And of course, is it infra-dig or beneath your dignity to listen to your staff? Not at all. Because a caring professional will not hesitate to listen and also not think that he or she is it or that he or she is the greatest. The Greek philosopher Epictetus said, we have 2 ears and 1 mouth so that we can listen twice as much as we speak. And the American playwright Eugene O'Neill said, God gave us mouths that close and ears that don't. That must tell us something. And in light of it, ladies and gentlemen, I refer now to the first 2 images at the upper left corner of the slide. You might notice that both have got lipstick on it. I didn't put that lipstick. This is as they came in the internet. And when you talk of speaking and listening and lipstick, they have obvious relationships. Now, as if on a time machine, I take you back to 1973. In mid-1973, I was the pediatric registrar in Ward 4 of the late Ridgeway Hospital for Children. Although, once again, I say so myself, not a bad-looking specimen that you see over there. I was probably just about 24 or 25 at that time. The medical staff in that unit was just 1 consultant, 1 registrar, and 2 interns. You can see now this has multiplied by a severe number. There are 2 consultants, several senior registrars, several registrars, several house officers in all these units at LRH now. Once a week on casualty day, the registrar was on call at night for the entire hospital. Now, it was no joke, covering all the wards except the professorial unit, because the professorial unit thought that they needed to have their own people dealing with them. They never trusted us, unfortunately. And that's Colombo professorial unit, I'm sure. It's not common to many other professorial units. And generally all wards had ill children who needed to be sorted out. And I said it was no joke because they are under other consultants, not my consultant. So if I go and sort of try to sort out those problems, I'm accountable to those consultants the next morning. And if you do something stupid, it will be taken to task for it the next morning. So one casualty night, I staggered into our ward around midnight, extremely tired and very sleepy. It was a really difficult night with problems everywhere. Thankfully, there were no problems in our ward, and I got ready to go back to my room in doctor's quarters and get some badly needed sleep. I was dead tired. But, and this was a big but, Dr. Perera, the house officer, would not allow me to go. Now that house officer, Dr. Perera, had just started the internship, maybe a week or 2 before that. And he was an imposing man with big physique, about 3 times my size. I was quite dainty, I would say, by many standards at that time. Perhaps only about 45 kilograms in weight. But this guy was towering over me all over. He wouldn't let me go. But I must say something else about Upali Perera. Before they came to do the internship, people told me that Upali is coming and a girl is coming with him and her name is Chinta and both of them are boyfriend and girlfriend and they are engaged to be married after internship. I thought, match over now, I'll have all kinds of problems. These two fellows will all disappear off and I will be on call, even on my off days. But the total opposite occurred. They wouldn't let one be on call. Both were on call. Neither would go home. So much so that their parents started complaining because these fellows won't come home. So the parents had to come to quarters to see them, rather than these two going home. Now this guy wouldn't let me go. So I said, what the hell, Upali? What's wrong with you? He said, no, don't go. I said, why? Suddenly, with great difficulty, he said, I don't like the look of that patient. So I said, which one? In the middle of the ward, there was a child. He said, okay, let's go and see him. We went, had a look at him. I mean, he had been admitted for a little bit of a cough and wheeze and things like that. Nothing very major. The child was reasonably. I said, Upali, he's all right. Can I please go? He said, no, please wait. And because he was so adamant, I listened to him and reluctantly stayed in the ward, calling him names under my breath, bloody stupid house officer type of thing. And it didn't take even half an hour. There was an almighty commotion in the ward, a mother wailing at the top of her voice, all the other mothers crying. So everybody started running around. We all ran. That child had stopped breathing. The same child who was fine before, at least somewhat fine. He had stopped breathing and the right side of his chest was bloated like a balloon and his heart rate had dropped to somewhere close to 20. And there was no time for anything. I didn't hesitate. I put a needle into his chest, into the second intercostal space in the midclavicular line at the upper border of the lower rib. And a whole load of air gushed out of that, whistled out, and the baby started breathing again. Cleared the cyanosis, and I turned around and said, somebody get me an underwater seal. So Chinta went running. She was the more agile of the two. And she brought an underwater seal. We connected it and air continued to gush straight out of the thing. But the child was all right. And then Upali said ever so gently, B.J.C, you can go now. I think he had some sixth sense. And I'm so grateful that he had that sixth sense, and I'm so grateful that I decided to listen to him. I shudder to think what would have happened if I had not listened to the house officer and gone to my room in the quarters. There wouldn't have been time for me to come back and put that needle into that, and that neither of the two interns would have had the guts to do that because they had just started the internship. The child would have died. And in the Latin words of the religion that I believe in, mea culpa, mea maxima culpa. Through my fault, through my most grievous fault, I would have had that death on my mind for the rest of my life. I would have been responsible for that death, for not listening to my house officer. The child recovered quite well and went home in about 2 weeks. And the reward for us was a beaming mother and a smiling child, with the mother trying hard to get him to bring his little hands together to say, Buddhu Saranai, for all of us. Incidentally, Dr. Perera went on to become a very respected consultant obstetrician and gynecologist later on. And up to date, I had never heard anyone say a bad word about him. The only time somebody said a bad word about him, when I called him a damn stupid house officer for trying to keep me in the ward. I said the second one was on this theme of altruism. And for those of you who are not very familiar with this word, here's the definition. It involves sleep deprivation, personal time limitations, meal denials, having to forego other commitments. And as Yul Brynner, that great actor, said after every sentence in that, as the King of Siam in that great film, The King and I, said, after everything, he said, etc., 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 etc. That means there's so much more to this than what I have listed. I take you back in time to December 1976 at Crawley Hospital, West Sussex, UK, where I was the medical registrar at Crawley Hospital, West Sussex, UK, and I was doing adult medicine simply because I had to sit for the adult MRCP exam. It was stupid for me to go and do pediatrics there, although I was sent for pediatrics, because we would have had to sit for, all the ministry wanted was the MRCP UK. So if that was the case, I had to provide the MRCP. So I was doing general medicine. And we had a 16-year-old, very pretty, petite English girl, Anne Gibson, being followed up in our clinic for very severe ulcerative pancreatitis. The entire colon was gone. And I really liked this patient because of her smile, with all her problems. I'm a sucker for a smile. And later on in life, I selected my partner also because I was a sucker for a smile. And she used to smile even with all her problems. We used to see her in the clinic. Then one day, she was admitted at 10 a.m., very ill and in shock. She had a toxic megacolon. And the colon had given up. And that meant that she needed a total colectomy and an ileostomy to save her life. We resuscitated her with IV fluids, analgesics, and IV antibiotics, and she became a bit stable. And surgery was scheduled for 1 p.m. I wrote on the drug chart and went up to the old battle axe of a ward sister with whom I didn't get on well at all. And specifically told her to give a single large intravenous dose of third generation cephalosporin and a large intravenous dose of an aminoglycoside just before the patient was sent to the operating theatre. She collapsed during surgery and gone back into shock again, and surgeons had just managed to finish the operation with great difficulty. And then I got a call from these surgeons and said, look, this girl is not going to live. She's very ill. So I said, what's the problem? So she went into shock and we can't get her out of it. So she has a medical problem now, not a surgical problem. They said yes. I said, okay, send her to the medical intensive care unit where I was kind of in charge, rather than to the surgical intensive care unit. They were very happy to do that because it was going to be one death less for them. They said, okay, we'll send. At 4 p.m., she was brought to the ICU, pale, unconscious, ice cold, dyspneic, in shock and in death's door. I was left holding the baby and I was off duty at 5 p.m. But I was not going to let her die without a fight. And the real reason was that battle axe forgot to give those 2 drugs to this girl before she went. These things happen even in England. And when the surgeons opened her, all the gram-negative organisms, it was like pulling the pin out of a hand grenade. It practically, literally burst in their hands. And all the gram-negative organisms flooded her bloodstream, and there were no antibiotics in the bloodstream to deal with those organisms. And she went into gram-negative bacteremic shock. She had unrecordable blood pressure, put down all the things, and if you look through this, and you'll know how ill she was. Her central venous pressure was going up and down like a yo-yo. One moment it's positive, one moment it's negative. So unstable the circulation was. And I had to keep that central venous pressure positive to get good filling pressure to enable the heart to pump the blood to the rest of the organs. But there was no way that she was going to live. She had no response to commands. A girl who used to talk very nicely to me, there was no response, no urine through the catheter. She was barely alive and was likely to die. And then I broke the ICU rules. And I spoke to the sister, and that sister was a very nice, accommodating sort of person with whom I got on very well. And I said, look, sister, this girl is not going to make it. So can we bend the rules and allow the mother to sit with her for the last couple of hours that she will be alive? At least she'll have a daughter for those hours. She said, okay, we'll do that. Then I said, can you please also allow the father to come in every half an hour or so to see the child for a couple of minutes and then go back? She said, okay, done. And then I hit her with everything I had. Oxygen at 8 liters per minute, intravenous fluids, vasopressors, blood, plasma, inotropes, furosemide, intravenous bicarbonate, broad spectrum antibiotics, intravenous steroids, the bloody lot. And nothing lost. I was dead sure that she was going to die. And it started a 16-hour vigil for a 16-year-old girl. Around 3 a.m., man opened her eyes. I bent down and asked her, how are you feeling, young lady? She just looked through me. There was no smile. Girl who used to smile so very nicely with all of us in the clinic. And that was bad news. By 4 a.m., urine started to drain through the catheter and the blood pressure became recordable. So I was spending my time changing the doses of the inotropes and the intravenous fluid administration rate, trying to keep that central venous pressure positive. Then very slowly her skin got warmer and her breathing improved. By 6 a.m., her central venous pressure, blood pressure and blood gases had stabilized, and I took her off the inotropes because I didn't want to burden her young heart too much. By 7:30 a.m., she was conscious, responding to command, and told me that she had no pain and was feeling okay, and she smiled. And that smile lingered on in my heart like a beautiful melody, because then I knew that we had won the good fight. I told her mother that we may be out of the woods, and there was hope. The mother, up to that point, was crying her heart out, and at one stage I told her, please, Mrs. Gibson, just sit there with her and hold her hand, give some of your strength for her to fight. By 8:30 a.m., the ICU nurses on their own fixed up bacon, eggs, sausages, tomato ketchup, toast, butter, marmalade, and coffee. It was not for Anne because she was on nil by mouth. It was for me and for Anne's mother. Neither of us had anything to eat after breakfast the day before. There's some more to this story. Anne recovered, was trained on the ileostomy and was sent home. We followed her monthly for about 23 months. She was doing fine, and every time she came to the clinic, she insisted on coming to me rather than even going to the consultant. And she used to run through and hug me tightly, put her head on my shoulder and say, my father gave me my first life, you gave me my second. Then in November 1978, I came back to Sri Lanka and forgot all about her. 4 years later, in 1982, I went back to the same unit as a locum consultant. And I was on a consultant ward round on a Friday afternoon. And we had a patient in the regional isolation unit for infection, because that's the regional unit that I was in charge of as well as a registrar, and in the top floor of the hospital. So we had to go and see this patient. And as we went to that ward, the sister there, another great lady with whom I got on very well, Irish lady, Terry Lynch. She gave me a very thick file, that thick, of notes, and said, "This patient is in love with you." And as I entered the room, the patient jumped down from the bed, came running, hugged me tightly, and put her head on my shoulder. And it was Anne, 22 years, married and heavily pregnant. And she had some loose motions through ileostomy, and the GP got all excited and got her admitted. She was fine. I have never forgotten what she said repeatedly: "You gave me my second life." It was Nat King Cole, American singer, jazz pianist, and actor, who said the greatest thing you'll ever learn is to love and be loved in return. Ladies and gentlemen, life could be full of surprises, and even miracles could occur. Sometimes one could be wrong too. The last one that I'm going to concentrate on, and I take you over to Ratnapura in 1985. Yes, one could be wrong sometimes, but the outcome could be good if one is lucky. April 1985, I was the consultant pediatrician in GH Ratnapura, and there was a preterm baby in the special care baby unit, first baby in the family, huge head at birth, massive hydrocephalus. And then he developed a severe brain hemorrhage on top of that, and that was the last straw. I very gently told the parents that there was no hope at all. They fell at my feet and pleaded, "Please do whatever you can and help us." She had obstructive hydrocephalus, severe spastic quadriparesis, just about 5 millimeters of cerebral cortex left on the ultrasound scan. We did not give him even a ghost of a chance to live. And I must admit, with some degree of shame, that I was hoping that he would die. Excuse me. But I was totally wrong. We did, because the parents were forcing us, we did all we could: tender loving care, physiotherapy, and active rehabilitation. A ventricular peritoneal shunt was put in by Dr. Fred Perera, a great professional in Colombo, right? Because I call him a great professional because he bought a special ventricular peritoneal shunt with his own money, didn't even charge it to the patient. The child got some head control only around 3 years of age. He began to walk quite unsteadily around 4 years of age. Severely spastic grade. But his mental and cognitive functions remained not too bad, actually. And a few millimeters of cerebral cortex that were left in him seemed to be functioning quite well. And then I was transferred to Kurunegala, and they followed me there. On my advice, the child was put into a normal school. There was a new school that had just started in Ratnapura. Mother had to help him to walk. And in all fairness, when he grew up, the mother couldn't do it anymore. All the boys in the school helped him. And when he had to go upstairs, they took the easiest way out. 4 of them just carried him. Simple. He had so much of support. Then I was transferred to Colombo, and they followed me there as well. He sat for the GC O-level examination. He was given extra time because of the disability, and they were allowed to get extra time. And I gave a letter to that effect. He passed that, and then he sat for the GC A-level examination. He passed that also and entered the Colombo University, first one from that new school. He secured a Bachelor of Arts degree, 2 postgraduate diplomas, 2 master's degrees, and is currently reading for his PhD. And if not for the COVID-19, by now he would have had a degree that even his pediatrician had not been able to secure. That's a PhD. The mother and the young man think that I'm the greatest. But I keep telling them, not me, but you and your mother are the greatest. I have permission from them to show this photograph at one of his graduation things for a MA, I think. You can see that the size of his head. It's virtually twice the size of that of his mother. Still. I have often wondered what would have happened if I had given up on him because there was no hope for him. I was convinced that there was no hope. Every time I see him, every time I speak to him, he reminds me of the words of the great English poet Alexander Pope, "Hope springs eternal in the human breast," and the singular words of Archbishop Desmond Tutu of South Africa. Hope is being able to see that there is light despite all of the darkness. I have always been one for self-criticism in my personal life, ladies and gentlemen. However, this time you are the jury and the judge. I have never believed, not even for a fleeting moment, that I am God's own gift to mankind. In fact, I am a man with very many faults. It was this man, a consultant physician, Dr. Ernest Victor Peris, who saved my mother when I was just 10 years old of an extremely severe diabetic ketoacidosis. And at that time, in the late 1950s, I think, no one with that degree of diabetic ketoacidosis survived. But this man, Dr. Ernie Peris, he was known as Ernie Peris, was the man who saved her. And later on, when I was a consultant, one day at a social gathering, I told him this story, how he saved my mother. It's a long story, so I don't want to bore you with that. And his reply immediately was, looking back, I believe I have done something worthwhile with my life. And I would like to use the same words to say, looking back, I too believe that I have done something worthwhile with my life. Ladies and gentlemen, it was John Bunyan, the great English writer and preacher, who said, "You have not lived today until you have done something to someone who can never repay you." For 99.9% of the patients that we see, they cannot repay what we do for them. But ladies and gentlemen, I don't know whether many of you realize, they have paid in full. They have paid up front because they have paid for education. I don't know about you, but if my parents had to pay for my education, I wouldn't be standing here today talking to you. Very often, all we get in return is a grateful smile for what we do for our patients. That is enough of a reward for many of us. Professionalism in medicine is the very first step, perhaps, towards even greatness. I would like to conclude with a bit of an apology. And when my former registrar, Dr. Uday De Silva, who's my great friend and colleague now, rang me maybe a month or so ago and told me to give this talk, I have grave misgivings because I was not sure whether I'm the right person to give this talk. I was worried, would many people ask, is this the same man? That is because I have had a reputation for being a hard taskmaster with a strict disposition, a flamethrower, a firebrand, and one who would not suffer fools gladly. But in mitigation, all I can tell you is that I did it for a certain reason, perhaps. And even some of the people in the audience, or maybe some others whom I met today, who had been students and had followed their appointments when I was in LRH, would join with the others and agree that I was like that. But in mitigation, all I want to say is it was probably because I cared. And in that context, it is relevant to bring here a comment made by the mother of a patient in Ratnapura. She had made this comment to a friend of mine, and it was made to me. අනේ අපෝ එයා ගිනි පුපුර වගේ නියමයට තරහ යනවා. හැබැයි ඉක්මනටම නිවෙනවා. ඒත් හිත හොඳයි. හොඳින් කියලා ඕන එකක් කරව ගන්න පුළුවන්. හැබැයි පුතෝ සල්ලි නම් මහත්තයාගේ බල්ලටවත් එපා. I don't think I have had a better compliment than that ever in my life. Ladies and gentlemen, appearance has changed, as you can see from there, and also looking at the man who's standing in front of you now. It has changed over a trek of 55 years as a doctor. And in that voyage, I realized that professionalism too, although it's a voyage, we need to learn and strive to improve every day during that journey. I only hope that I have aged graciously, softened, matured, and improved over the years, just like a fine old wine. Ladies and gentlemen, it's just about time, I think, now for me to take my leave. I put this slide for a specific reason. As an accolade and tribute to two of the greatest mentors that I have had. And one was late Professor C.C. De Silva, where I had the audacity to write my very first scientific paper in the second half of my internship. And I was sent to him for the paper to be reviewed. And he sat me down on a beautiful antique couch in his residence and proceeded to take my paper apart in red markings. Not a single sentence survived. He cut it, chopped it all over the place and said, "My boy, you have got a lot to learn," and wanted me to type it and bring it back again with all the corrections. So now that time, those were days well before word processors, computers and that kind of thing. There was this monster, huge metal typewriter, and you had to type it on that. And I was not a great typist. I was what is called a co typist. That is, co A, co B, co C, co D, like that. I had to look for the keys. So I typed the thing again with all the corrections and took it back to him. He cut it again. He chopped it up again. And to cut a long story short, this went on in no less than 7 times. And the 8th time, I refused to go to him and went to the editor, who was Dr. Perera de Silva, and said, "Madam, I can't do this anymore." So she looked at it and said, "No, I think it's okay now." Right, we'll publish it. And it was published. And from that time onwards, Professor C.C. De Silva took a personal interest in me and taught me all the details of how to write a scientific paper. So I have the greatest regard for him. I would worship the ground that he would walk on. The second person is late Professor Carlo Fonseca, who actually used to very often call me his son. That was such an honor to be called son by such a great man. And he taught me how to make presentations. And he used to come for all my presentations, sit at the back, and then go through the thing, and at the end take me to a side, very gently point out all the things that all the mistakes I made, and I was always the richer for it. I appreciated what he did. Then one day, he sat at a presentation, came back and said, "B.J.C, that was a faultless presentation. There wasn't a single fault till you showed that last slide." And the last slide said, "Now it is time for me to take your leave. And he said, you're not taking leave. You can't take somebody else's leave. You can take only your own leave. I was dead sure that the great man was wrong for once. So when I checked up the literature, and even now, even when you check this up in the artificial intelligence, you get the same answer. He was dead right. And he taught me all the things. And I put this up now in the correct English. Now it is time for me to take my leave. And ladies and gentlemen, these two gentlemen, among very many others, they polished a raw nugget. And I have tried hard to do the same for those who came after me. On this great day, I have the greatest pleasure in wishing Madam President and all the office bearers of the Anuradhapura Medical Association all the very best. And I hope and pray that you will go from strength to strength and be a beacon of various things about general medicine as well as professionalism, as a beacon of hope for the rest of the people. Before I take your leave, ladies and gentlemen, for those of you who have fallen asleep, it's time to wake up now. As for the others, I would love to join this beautiful young lady and say, thank you so much for your company. Have a great evening and good night.